Hi, everybody. Thank you for having me here today. It's my absolute pleasure that I could be worked into your schedule, given that it's the last week of the semester. So I appreciate the honor and the chance to speak to you today. So my talk today, it will review some of the work that we have been doing at the intersection of social media and mental health over the past few years. I'll talk a little bit about where the opportunities are, where we stand, what seems to work, what doesn't seem to work, and kind of what are we missing at the moment. And then I'm going to talk about a couple different case studies to kind of reflect on potential ways to go about filling some of the existing gaps. All right. So, so we all know that there are a lot of data and digital traces that are being left behind by people on different social media platforms. And I would say over the last decade and a half, we have seen the emergence of a new field called the field of computational social science. And it has made a lot of significant strides into sort of improving our understanding of a number of different social phenomena. For instance, if you look at social media data in particular, these are provided us new ways to measure social interactions, our moods, our political ideologies, and our collective action. And then we have computational social scientists, including both computer scientists and social scientists, who have been making a lot of contributions to improving our understanding of a number of different things like political events and outcomes, crisis. We are living through one at the moment. Civic engagement around social unrest and protests, also something we have seen a lot in the last 1 year, and health and well-being, which is going to be the focus of my talk today. So in the initial part of this talk, I will highlight some of the work that my collaborators, my students, and myself, we have been conducting over the last few years that showcases the computational use of social media data for mental health. And then I'll spend the large part of this talking about the next frontier, and I'll particularly talk about how sort of we can think about collaborative ways and synergistic ways to advance this field going forward. So I'm going to quickly highlight a series of projects, and I'm going to adopt a well-known framework for that to showcase these examples, and that is called the social ecological model. That allows us to think about these computational uses of social media data in different granularities. So let's talk about the individual granularity first. So some of the earliest work that we did in this context wanted to understand what kind of changes in people's behaviors and emotions can we understand by looking at the social media data around major life events. And here's, we looked at a specific life event that is something that many people experience and also something that people do discuss on social media, and that is the birth of a child in a family. So we looked at new moms and their announcements of their childbirth, both on social media as well as through self-reports. And we looked at the Twitter data and Facebook data that spanned several months preceding and succeeding those events. And what we found is that we could look at the data that preceded these life event announcements of these new moms, and we could extract a variety of different behavioral affective measures that would indicate which new moms were likely to go on to be at risk of postpartum depression in the future. So what were some of these measures, for instance? We found that oftentimes the moms who were at a greater risk of postpartum depression, they showed declined social activity, they used more negative affect, the emotions that they were displaying on social media that had lower psychological arousal. And also we saw some interesting patterns with pronoun use. For instance, the new moms tended to use more first person singular pronouns. So we wanted to see how these observations corresponded with validated screeners of postpartum depression. And we found that we could build predictive models that would take into account these markers of behavior and affect, and could allow us to predict which individuals were more likely to be at risk. So I'm going to talk about the implications together once I give you an example of the projects at the community and the population level. So, but let's talk about the population level assessments next. So in this work, we were interested in communities, drawing from the social ecological model, and we were interested in situated communities. So essentially a set of people who have a shared set of experiences because they're geographically co-located. We looked at college campuses in this case, and we were interested to see how these communities responded to different crisis events. The particular set of crisis events that we looked at in this work, that included gun violence incidents. So we looked over a 5-year period, 12 incidents of gun violence that happened in 12 universities in the US. And what did we find? So we looked at subreddit data, which were essentially dedicated online spaces for individuals in these universities to come and talk. We found that we could develop models that would assess the levels of stress and anxiety experienced by these communities by looking at these postings on these subreddits. And when we try to understand what happens to these levels of stress in the aftermath of these gun violence incidents, we found that expectedly there was an increase in levels of stress. But what was more interesting was what kind of language was associated with these spikes following the gun violence incidents. So we found, for instance, that there was a decline in academic topics and academic discussions, which would be common in high stress postings in the period prior to these gun violence incidents. But in the aftermath, we saw a decline of those type of word uses. And instead, we saw a lot of social words such as people, friends showing up, which aligns with the literature in crisis psychology, which would tell you that when people experience a crisis, these kinds of social engagements, these sense of solidarities increase, and people reach out to each other, both for help seeking as well as to provide help to others. And that's kind of what we were seeing in these communities as well. And it was possible because we were able to look at the social media postings of these individuals in these campuses. And then thirdly, what about the population? So in this work, we developed what is known as the social media depression index. And the idea here was to identify using a classifier trained on crowd worker volunteer data on depression to measure whether a posting that comes from a certain geographical location at a certain point in time can be assessed whether it's likely to be indicative of depression or not. So when we applied this depression index at the national level, this is what we found. So you see two heat maps over here in the slide. On the left, we have the actual prevalences of depression that were given by the Behavioral Risk Factors Surveillance Survey, which is a survey that happens every few years, conducted by the Department of Health and Human Services. And then on the right, you have the predicted levels that were given by this depression index. You could eyeball, you could compute statistical measures, but what we found was that there was a high degree of correspondence between these two heat maps, in that eyeballing, you would see that the lighter shades corresponded with lighter shades and the darker shades corresponded with the darker ones. And then in addition, we were able to glean a variety of different socio-demographic and spatiotemporal patterns using these measures, something which is not possible to do in a real-time or a near real-time fashion when you're relying on surveys. So for instance, we found that we could use this index to identify sex and gender-based differences. We could identify diurnal differences in expressions of depression, and we could also identify seasonal changes in experiences of depression using this measure. Of course, there are plenty of other examples that I would love to talk to. The potentials of this research have been showcased by many other scholars, some of who are actually on this call, in a variety of different contexts, a variety of different platforms, mental health domains, different populations, and you could see the potential being demonstrated time and again in these excellent pieces of work by these illustrious authors. So now the question arises is, what comes next, right? There is a lot of potential, and you might be wondering, what is sort of the next thing in this line of work? Are we ready for real world deployment or uses of these models in practical settings? And what would be the best way if we wanted to do that? So let me talk to you about some of the potential implications of these work that I just told you about. So one of the most promising potentials is to use these algorithmic insights to connect people in need and in distress with timely and proactive help that is either mediated by a technology or delivered through some form of a technology, and it would allow people to receive interventions in response to their needs. And then there is also immense potential for, let's say, community organizers, when we talked about the community level assessments, as well as for stakeholders in public health to harness these kinds of insights that are given by these predictive models to influence, let's say, policy as well as decision making. The question is, what is preventing us from pursuing these directions, right? Why haven't we reached these practical uses so far? So in my view, there are two important questions that are yet to be answered in this field before we can actually take these methods and we can use them to fulfill the promise of interventions, policy impact, decision making, and so on. The first question is, are assessments that we are getting from social media and are they efficacious on people who actually have who actually are suffering from a mental health challenge? So to answer this question, let us kind of reflect back on this body of work that I just told you about and examine how can we assess the domain-specific efficacy and validity of these assessments that allow us to measure mental health states of individuals. So the reason this is an important question and why it makes sense to go back to this field is to look under the hood. What was really happening all this while? So one question that would stand out to you is the question of ground truth, right? We are dealing with a domain that is very, very sensitive. We are dealing with individuals who are vulnerable, right? The highest quality ground truth data that you could potentially gather for this domain are actually clinical assessments of some shape or form. But the challenge is that because of these sensitivities and these vulnerabilities that exist in this field, clinical assessments are really hard to gather. So what a lot of the researchers have done is they have appropriated these proxy ground truth labels. And the reason is that anything that you see on the very left of the scale is difficult to do because this is a very unique machine learning problem. It's a supervised machine learning problem in most cases, and it's hard and very much different from what you see in computer vision or other classical machine learning fields where you have an objective ground truth and you could just collect that ground truth with enough person power, such as with crowdsourced labels or engaging undergraduate students in a lab. That is not possible in this case. So that's why researchers have appropriated this middle ground, which is essentially proxy ground truth labels. And the idea here is that there are probably certain kinds of behaviors and expressions on these social media platforms that are gonna tell us something about somebody's underlying mental health state. And that potentially that data is easier to gather than your clinical assessment-based ground truth, but actually is higher quality than having random people annotate who might be at risk of a mental illness. So it sounds like a promising middle ground, and we have seen a lot of research coming with that approach. And some of these proxies that have been adopted could include things such as whether somebody follows or shows an affiliation with mental health organization, support organization, or a mental health community. It could be somebody self-reports that they are likely to be suffering from a certain mental disorder, and so on. In some cases, we have also seen that there are experts who validate some of these postings on social media as a way to assess if they might be at risk of mental illness or not. So now, given this, we need to identify whether proxy ground truth labels are actually doing the job that they're supposed to do or not. And remember, the two questions are validity and efficacy that we care about for real world translation. So the questions that we asked in this work was, the first one was around construct validity. So the question is, do the proxy diagnostic signals that are obtained from these behavioral patterns, do they objectively and accurately measure what they claim to measure, right? In this case, a clinical diagnosis or assessment of mental health. And then theoretical and clinical grounding, which relates to the question of efficacy, which is, can we be sure that what is being measured by these proxy diagnostic signals, is that valid in itself when it comes to the specific domain that we are talking about, in this case, mental health? So to answer this, we constructed different data sets. So we looked at three kinds of proxy behaviors common in the literature. So affiliation data, whether somebody associates themselves with a community or follows a certain set of accounts. Self-reported data, which is somebody says that I'm suffering from a certain mental disorder. And then appraised data, which is essentially a filter that is often put in place on top of these self-reported data to clean up a genuine self-reports of a mental health diagnosis. And then we constructed matched control data for each of these samples where that specific proxy behavior was absent. In addition, we had patient data, because that is sort of the ground truth, the gold standard we are comparing these proxy models against. So this was patient data that came from a set of individuals seeking treatment for their schizophrenia diagnosis at a big health system. I'm going to talk more about this data set in just a bit. And then we had healthy control data, essentially for clinical and medical studies. These are individuals who have been diagnosed by a clinician to not suffer from the specific mental illness, in this case being schizophrenia spectrum disorders. So we had a triangulation approach that we adopted here. The idea was to train a number of models for internal validity, which is the idea that we train these models on the specific proxy behavior and test it on a held out data set of the same proxy behavior. So that would demonstrate internal validity of the models. And then external validity, which is the idea that you take the trained model from a proxy behavior and you see how well it does on unseen held out data of patients. So it was, for simplification, we adopted a binary classification task and we used language features in these postings. The data came from both Twitter and Facebook. What did we find? So let's talk about efficacy first. What we found is that these models actually do very well when it comes to their internal validity, which in a way is a replication, and it reproduces the findings of other researchers in the past, which is that we can do pretty well in predicting the proxy behavior, which we think is an indicator of their mental health state, by their social media platforms. But the interesting part is in terms of the external validity. So if you look at these numbers, which are only reporting accuracy here, we notice that these models actually do not do well at all when it comes to applying them in the context of patient data. But the interesting part is the patient model. If you look at it, it consistently does well, both in terms of internal validity as well as external validity. So basically, this begs the question of efficacy, right? So if we are to take these models that are trained on proxy behaviors and we want to apply them on actual patient data, because we want to make interventions to help people, we have to be concerned at this point about the efficacy. The next item was around construct validity. Again, are we measuring what we think we are measuring? So one way to answer that was for us to see what are the top predictive features of each of these models. So here we took the worst performing proxy model, which was the affiliation model, and the best performing proxy model, which was the appraised model, and then the patient model. So you could just eyeball these features in the three columns and look at the overlap. And what you would notice is that there is so little overlap of affiliation and appraised models with the patient model. So while these models do very well in terms of internal validity, and they're predicting what they're supposed to predict, which is the specific proxy behavior, but we cannot be sure if they're actually predicting the clinical mental health diagnosis of a specific patient, because if it were, you would see a great deal of overlap between these two models on the left and the patient model. So again, it begs the question of appropriate levels of construct validity in this research. So basically, the main takeaway here is that if we want these models to translate in the real world and be incorporated into interventions in some shape or form, we have to take long and hard lessons about efficacy and about the validity of these models. It raises many important questions that we need to answer going forward. So for instance, if these measures are, what are the risks when we apply these methods in the context of clinical population? What kind of dangers are we incorporating? And potentially not everything is bad. There could still be potential uses of using these models in an intervention setting, but we have to brainstorm what those interventions could look like. But the takeaway here is that the patient model, when we build these models, a patient data that were voluntarily shared by patients, we consistently did well. So it almost begs the question that if you were to think about clinical translation in a health setting, for instance, we have to work together with the patients, together with a health system in a collaborative fashion if you want to have a real world translation of these approaches. On that note, I'm going to move over to the two case studies, which hopefully offer one way. And again, I'll iterate, it's not the only way, it's one way to think about addressing some of these gaps in efficacy and validity. The hallmark of both of these projects is that they have been synergistic and they have been collaborative, collaborative work that has spanned multiple years. And these are with stakeholders who are out in the real world working with people challenged with mental illness. So the first case study is a case study which is a partnership with Northwell Health. They are one of the big health systems in the state of New York, and they do a lot of cutting edge investments in research in mental health as well as in treatment of patients. The project that we are working on is called Thrive, and our broader goal here is to see how we can, take that social media data has provided us and think about designing and building clinically facing tools that are powered by the data of patients, the data that is being voluntarily shared by patients, and also thinking about how these tools could cater to different stakeholders within the health system, most importantly, the patients themselves, as well as the clinicians. So the specific question that I would like to talk about here is a question that comes up a lot in psychiatric treatment, and that's the question of relapse. Relapse can happen for pretty much all mental illnesses, but one illness for which it is a real challenge are schizophrenia spectrum disorders. Schizophrenia as such affects only 1% of the population, but if you look at individuals struggling with this illness, you've noticed that even for those individuals who are under treatment, about 80% of them have a high risk of relapsing in the next 5 years of treatment. But the challenge that our clinical partners from Northwell told us is that oftentimes they get to know about a relapse after a relapse has happened, which is when the patient comes back to the health system, meets a doctor, and has to be immediately hospitalized. So the clinicians wanted to change the status quo. And the question here was that, is there any opportunity for early identification or a proactive identification of relapse that we could gain by looking at patients' social media data? Because then it could empower these clinicians to take actions that could potentially prevent the relapse from happening altogether, such as new therapy, medication adjustment, changes in social context and experiences, and so on. So with that question in mind, like I said, it's a collaborative effort. We were interested to see how patients felt about this question being addressed. Patients are a very important stakeholder in this research, of course, because eventually they are the ones we want to benefit the most, but they are also the ones who are at risk of being harmed by these models. So we ran several focus groups and interviews with patients at this health system in order to understand their attitudes towards sharing of data with clinicians and clinical researchers and their partners, and what they felt about this data being used in a way to identify risks of relapse. We saw overwhelming positive response because patients thought that this was an opportunity for them to participate in some work that could have a positive impact in their own lives or in the lives of their peers. So this study is still ongoing, but the specific results that I'm going to be talking about are at a point where we had recruited about 110 early psychosis patients who were receiving treatment at this health system. About half of them had a relapse, and here relapse was defined as a hospitalization due to exacerbation of symptoms in early psychosis. These participants shared with us full archives of their Facebook data, and that, despite the small n, gave us access to very rich longitudinal information from these individuals. So now let's talk about our modeling considerations. And again, why that is, it's such an important, it's so important to have that collaboration in place. So on the surface, if I coming into this project as a computer scientist would have thought that, this is just like a supervised machine learning problem, right? Because I have ground truth data on relapse hospitalizations, and I'm just gonna see whether Facebook data in this case allows me to predict those labels. But here's the challenge. Relapse events are multifactorial, and they manifest in many different ways in many different people. So there isn't a pattern that you could learn by looking at all of the social media data together. Clinicians in our team said that it's heavily associated with clinical heterogeneity, in that one person's symptoms may never look like the symptoms of another person. The bigger challenge, although, was the fact that there are no true positives and negatives in this problem setting, because any individual has a non-zero chance of relapsing anytime in the future. So this makes it hard to take traditional machine learning approaches and actually make them useful for the clinician, because the clinician is not interested whether the model is able to distinguish between those who relapsed and those who did not relapse well or not. The clinician wants to know whether, for this specific patient that is right in front of me at the moment, what should I be doing? Is this person at risk of a relapse or not? And what can social media data offer me on that front? So to predict this rare event, which is a relatively rare event in a psychiatric context, we framed our modeling as an anomaly detection problem. And the idea here was to look at, for every individual, to look at healthy periods where there was no hospitalization, and then relapse periods, which were essentially a period of 1 to 3 months preceding the hospitalizations. So we trained a one-class SVM model, which is a classical anomaly detection approach, and we wanted to see how well we did. So this is how well we did. We did pretty well in terms of specificity. So again, the definitions of specificity and sensitivity are swapped for an anomaly detection problem. Here, specificity means relapses predicted as relapses, and we did pretty well in that. We had, we were successful for about 79% of the cases in that prediction. What we did not do well on was sensitivity, which is the model thought certain periods were relapse periods, but in our gold standard data, those were marked as healthy periods. And in terms of this, we only were correct 37% of the times. So now, again, a collaborative approach allows us to dig deeper into why these models sometimes work and why do they sometimes not work. So to answer that question, we did an error analysis where we looked at clinical charts, another source, complementary source of data that was available to us through this collaboration. Essentially, these are notes, unstructured notes that are noted by clinicians following their appointment with a patient. And we found that we had some notes of usable shape or form for about half of the false negative cases. But for about 90% of these cases for which we did have something in the chart review, we did notice that the clinician noted that this person's psychotic symptoms actually had exacerbated at that point in time. But given the subjectivity that lies in clinical treatment, especially in psychiatry, at that point in time, this clinician did not assess it to be severe enough that would warrant a hospitalization. But because that backstory was not a part of our ground truth, we only looked at binary labels of whether somebody had a relapse, hospitalization or not. That knowledge was missing to our models. That context was missing to our models, and our models interpreted that, yeah, this is not it. This person is healthy at this point in time. So basically, what it tells us is that, such a collaboration allows us to obviously identify, when the models work, what they're good at. But this piece is equally important, if not more, which is when are they not working? Why are they not working? So now with this background knowledge, when we think about clinical interventions, clinicians can be better empowered to act on this information that, yeah, I mean, sometimes the sensitivity can be wrong, can be poor for these models. So I still need to use my clinical judgment in a certain way to factor that into account. So the broader takeaway in this work, though, is that, it allows us to go beyond sort of population-based, group-based models of traditional supervised learning, such as classification that we have been seeing in the prior research that I just reviewed earlier in the talk. And it allows us to look at the person as the unit of the analysis, because at the end of the day, if you think about clinical treatment and intervention, it is about the individual. It is not so much about what is going on with the broader population. And what we showed here is that with these personalized methods, we can actually longitudinally forecast certain events which might also be rare, such as relapse. So these personalized approaches, they have a lot of opportunity to inform clinical decision-making, because now the clinician knows how to use the model to support treatment a specific patient. It can allow people to connect with appropriate, let's say, culturally or context-sensitive technology-mediated support resources, or to help, let's say, nonprofits who work with vulnerable communities to direct specific resources towards certain subgroups that might match better with their context and their needs. So now, finally, this is the second case study that I wanted to review. And it is also a collaborative work that where we partnered with the Centers for Disease Control and Prevention, and it's been going on for the last 2 years now. And our central goal here has been to think about suicide prevention efforts that CDC is keen on and undertakes, and how those efforts could be informed by what we can learn from social media data in conjunction with other kinds of traditional public health signals, which are already used by organizations like the CDC. So the main motivation in this work was that, the rates of suicide in the US in the last 20 years, they have been increasing across different demographic subgroups. Of course, there is an interest to know why that is the case, but what is even more challenging from a practical perspective is that we don't know how much it is going to change in the next year. There is actually no real-time information on suicide fatality trends that could guide the prevention efforts that CDC could plan going forward. So this this poses a lot of difficulty to CDC to make like budgetary decisions, deploy interventions beforehand, because currently we are in 2021, and the most recent data that the CDC has access to around suicide fatalities is from 2019. So that's a problem, especially when we're living through a pandemic and we want to deploy those resources to vulnerable communities. We want to have a real-time resource. So the main motivation in this work was to see what is it that social media and online data can offer, and how that fits together with traditional forms of public health data. So in this work, we developed essentially a machine learning pipeline that harnessed signals from various different streams. So we had data that came from social media. We had data that came from health services administrative data, such as visits to emergency room departments, we had data that came from calls that were placed on the National Suicide Prevention Hotline and calls placed on the Poison Center hotline due to overdose of a certain specific substance. We also used macroeconomic data. We used meteorological data, and in web data, we used social media, search engine trends, and so on. The idea here was that all of these data sources, if you think about them individually, they're not adequate to answer this question of national level trends. We have knowledge about what happened with Google flu trends when we only used Google search trends to predict the flu. Over time, that model stopped working. So the goal here was to see how we can take a synergistic approach. The fact that, the person who picks up the phone, the National Suicide Prevention Hotline phone, to being in distress, is probably never going to share about that on social media. And the person who shares about their suicidal thoughts on social media might never show up in an emergency department. So, but when we put all of these data sources together, it allows us to get a much fuller picture of what might be going on. And that is an important piece of information from a public health perspective. So machine learning framework, what it essentially did, was that it had two phases. In the first phase, we trained individual models that corresponded to each of these data sources. And then we combined them in an ensemble fashion using a deep neural network that allowed us to take the knowledge from all of these weak learners, combine them in an intelligent fashion that would allow us to come up with a composite estimate of suicide fatalities in the country. So what did we find? There are a lot of numbers in this table, but I would like to draw your attention to the last row here, which is the row called all data sources. So what we find here is that when we combine these data sources, expectedly, we do the best of all of the ensembles. But if you also look at some of the other ensembles, they also do much better than single data sources. So importantly, if you look at this final ensemble, it outperforms predictions that were made by our best performing baseline model, in which case it was a Holt-Winters model, which is a seasonal model that allows us to predict a suicide in the next week based on the historical rates of suicide in the past. So our ensemble model did significantly better than that. It improved the correlation while also reducing error of these weekly estimates by almost half. And the error of the annual estimate of suicide, which is the number of suicide deaths per 100,000 of the US population, that was less than a tenth of that baseline model. So basically, going back to our initial motivation, which was that, currently we don't have any established way to gather real world signals about suicide fatality trends. And that is incredibly important because we cannot be working with 2-year-old data when we want to make our budgetary decisions and deploy suicide prevention policy and interventions. What this tells us is that, we have seen a lot of predictive work that looks at, let's say, social media data or Twitter data or something else and tries to predict an outcome. But there are limitations to that because not everybody is on social media or not everybody shows up in an emergency department for a risk of suicide. But what it showcases is that when we take a domain sensitive approach, which was consultation with public health experts and the role that each of these data sources play in the context of public health surveillance, we are able to put them together in a way that would allow us to get a much fuller, much richer and comprehensive picture that would allow us to counter some of the problems that we have seen in big data for health in the last several years. So at the moment, CDC is very interested to take these models and make these a part of their suicide prevention surveillance, but there are lots of work to be done in this case further. For instance, can we go from the national level to more finer grained subgroups, specific communities, specific sociodemographic groups, specific specific geographical areas, because that can even empower organizations like CDC to take this information and have it make an impact in the lives of people who need those interventions more than others. So, I would start to wrap up at this point. I mean, of course, the two case studies that I just discussed, they show a lot of promise about how we can begin to overcome some of the limitations in efficacy and validity that this field has seen in the past, and how can we move forward where these models can now become a part of the work that clinicians do, that public health organizations do, or maybe another stakeholder might be interested in. But I would note that these are still far from complete, and I recognize that there are still a lot of unanswered questions remain and would need to be addressed going forward. The first, of course, is the recognition that it's not just a technical problem that we are addressing here. We are addressing here a socio-technical problem because it's not Kepler's laws of motion, right? These are the lives of real people like us. The models that we build, that they can have significant impact on what happens to these people. We want to believe that these models will help, but I think we cannot lose sight of the fact that they can also be intentionally or unintentionally be used inappropriately to harm individuals. So, there are questions of, basic questions of algorithmic performance, right? I mean, what level of performance do we need for these models to now be a part of the real world? I mean, there were questions in the tensions between sensitivity and specificity that I talked in the case study. But the question is, now we understand why those numbers, we are getting those numbers, but can we now use this model in the real world? We don't have good questions for that. There are questions of a gap in expertise and mental models as well, because are building these models, we are not the world, the set of people who are engaging with these vulnerable individuals and communities. It is somebody else who obviously know their job much better than we do anything about that field. But what happens when we take a model which has a very specific mathematical representation and we try to shoehorn it into a specific mental model of psychiatrists or public health workers, which probably is very different from how we conceptualize and think of these machine learning models. So that gap has to be addressed. Relatedly, there is the question of right? I mean, now we are saying already incredibly busy psychiatrists and clinicians and public health workers is that, hey, by the way, on top of everything else you're doing, here's another model and another source of data that we think will be useful for your work. That can sound like overburdening these individuals. So we have to find ways to probably rethink the institution of mental health care and mental health when it comes to public health interventions, about how they can become, how they can find mechanisms to support these individuals and support them with these algorithmic data-driven insights. There are obviously still a lot of questions about privacy and ethics. These research, at least the individual level ones, conducted by getting informed consent from the patients. But of course, lots of questions about the therapeutic relationship, the liability that is posed on the clinicians and public health workers when you're looking at these machine learning insights. Who takes the responsibility when the model is wrong, right? We don't quite know. And then, of course, there are questions of social justice, right? One question that I got at a talk many years ago is that, what about those people who don't use social media? Should we leave out those people in our society? Of course not. But then this is a real question, because everyone is not on social media. And if these models are really useful and these individuals for digital divide, for other socioeconomic reasons, are not using these technologies, we need to find a way to bring help to them, probably through other ways. And we need to make sure that these technologies are not creating new forms of discrimination and new forms of social injustice on top of what exists in our world today. So that is what I have for you today. So I would like to thank all my students, my postdocs, my collaborators, and the sponsors of these projects, without whom none of this will be possible. And thank you for listening. And I think I have a few minutes for questions.